Hi everyone, we have just let 60 plus people into our Zoom call. So welcome everyone. Welcome to the PCNA webinar. We're just going to give everyone a couple of minutes before we get started. We'll give everyone 3 minutes and then we'll get started. And while we're waiting, I'd love you to put in the chat, just introduce yourself, your name and what service you've come from. Because this is my favorite bit of the webinars, is watching where we are all joining from. It's just an amazing thing. Who wants to be first? Now I've got to be able to see the chat. Hi, Evelyn. Thank you, Evelyn from Melbourne. Hi, Beck. I know Beck from Catherine. Christy, welcome, Christy. We've got Candice from Melbourne, who's a doula. Thank you for coming. Jess from Penrith. Tunya from Shepparton. It's so exciting, isn't it? So cool that so many people join from WA. Hi, Justine. Nikki from the Sunshine Coast. Are we going to cover every state? Let's have a look.
Here we go. Byron, Vicky from Byron. Hello, Vicky.
Libby. Hi, Libby. Vicky. There we go. Jackie from Wangaratta. Michelle from Perth, thank you for coming. We're just, as people join, we're just giving everyone a minute. 82 is unbelievable.
Wow.
Melissa from Queensland. Hi, Karam. Hi, Karam from Wagga. I used to live in Wagga, close to my heart. Kira and Nadine from Townsville. Hi, everyone. Thanks for coming. This is huge.
Jodie from Townsville. Hope you're okay in Townsville.
Yeah, that's right. Wow, this is huge. Now I'm thinking I might not be able to go through everyone's name, but okay, I think we get started, and people will continue to join and we'll let them in. Amazingly, we've got 88 joined so far. That is incredible. So, welcome. Hi, everyone. My name is Sarah, and I am a community palliative care nurse. And I was from Melbourne, but I'm currently living in Darwin at the moment. And so welcome to our first PCNA webinar, and we're in for a treat because we've got Cohen, and I'm going to introduce him in a minute. And he's going to talk to us about a topic that I think resonates with us as palliative care nurses, which is tricky to manage pancreatic cancer pain. But before we get going, I'm just going to do an acknowledgement of country. So at PCNA, we acknowledge that we all work on sacred lands and waterways that belong to different traditional custodians. And for me, in Darwin, that's the Larrakia people. We recognise and acknowledge and seek to stand side by side with First Nations people as they strive to overcome the impacts of colonisation and dispossession, causing impacts on their health and well-being. We honour and we admire and celebrate the Aboriginal and Torres Strait Islander people who represent the world's oldest culture, their strength, resilience, and interconnection to all living things and grounds, and inspire us. So, welcome. How many are we up to now? I'm a little bit excited by how many people we have here.
96.
96, that's crazy. So, before we get going, a little bit of housekeeping. If you can mute yourself, that's very handy. The other thing that I find is really helpful, and there's no pressure to do so because I understand people are probably at work, is turn your camera on, because it helps Josh and I feel like we're not talking to just like an abyss of the internet. Now someone's in there. I'm going to mute that person. There we go. Yeah. So just keep your microphone on mute. It'll make it easier for everyone. What I'm also asking people to do is to introduce themselves in the chat. The way this webinar will work is I've got a set of questions to ask Josh, and we're going to have a conversation about tricky to manage pancreatic cancer pain. And as we, that's okay, Vicky said, I've got no camera. As we are talking, if a question comes up for you and you are thinking that's something that I think everyone could benefit from, please pop it in the chat. And we've got a friend, a colleague, Aileen, who is there, and will keep an eye on the chat and ask the questions for you at the end. Given that we have over 100 people here, we may not, 100, we may not be able to answer every question, but Aileen will try and get the questions that are the most relevant to everyone. Okay, hooray, so we can get started. So my first thing to do is to introduce Josh to you. So thank you very much, Josh Cohen, for being here. So Josh is a specialist. He's been specialist palliative care nurse for 15 years, and he's master's in palliative care and also a master's as a nurse practitioner. And probably the most important thing to know about him is that he's currently working in New South Wales. Is that right, Josh? And yep. What service are you currently working in?
So I work up in northern New South Wales for the specialist palliative care service that looks after people from Grafton right up to Tweed and out to Casino.
All right. Well, thank you so much for joining us, Josh. So what we're going to do, before we go in and I ask you the first question, I thought it might be helpful to give everyone a bit of context as to why I chose this topic. At PCNA, we're trying very much to choose topics that aren't covered frequently. And this, for me, was one of them. And I remember I've worked as a community palliative care nurse everywhere. I feel like it's been everywhere. And one of my jobs was as an outreach nurse from Wagga. And I remember meeting this lady in actually, I shouldn't say the time, this lady 3 hours from Wagga. And she was the type of lady who you'd ask her how she was, and she'd say, "Oh, I'm as rough as hedge undies." Like she was just a salt of the earth character, and she had pancreatic cancer, and we were referred by the community nurses she had escalating doses of opioids, and when we arrived, after assessing the pain, could really figure out that we weren't treating the right type of pain for this lady. And when we switched her to methadone, that was when she started to get some quality of life. And I just remember the suffering of this lady. And I wondered whether that resonated with other community nurses and other community palliative care nurses across Australia. So that's how we got to this topic. So, Josh.
Yes.
Does that story resonate with you?
Look, I know, yeah, absolutely. Certainly, when you're going through your books and you're looking at people who you can discharge and who you can't discharge, people with pancreatic cancer are always going to be keepers, because we know that there's going to be a level of complexity to their care. And, there are also, a whole lot of different ages that get pancreatic cancer as well. And I think when we hear about a pancreatic cancer dose, it's a bit like ovarian cancer. We think this is going to end with this person dying, and potentially over a short period of time they're introduced to our service. So, and absolutely that their pain management is likely to require the full gamut of the multidisciplinary team to manage their needs.
Yeah, absolutely. So I guess before we go to the pain, the kind of assessment and the management of pancreatic cancer, I wondered if we could start a little bit more basic and just go, Josh, would you explain to everyone what are the mechanisms and pathophysiology of pancreatic cancer pain? So why are these patients getting this pain?
Yeah.
And maybe in that answer is, why is it so tricky?
Yep, sure. Okay. So the trickiness, I reckon, we'll get to and we'll keep touching on throughout the talk. But the mechanism and the pathophysiology. So, it's difficult to keep it simple because it is complex.
Yeah.
But before everyone came into the room, we were saying, nurses are pretty pragmatic. And I think as long as we have, and actually, I think as long as we're continuing to ask why, we will usually end up in the right place as to the mechanism of pain. And we all know in palliative care, so long as we're asking that really critical question, why is this person presenting the way they're presenting? And are they presenting in a way that we would expect them to present given their diagnosis? So obviously we're talking about a diagnosis of pancreatic cancer pain, and probably by the time we're involved, by the time a palliative care service is involved, they would have metastatic, unresectable, whether it be locally or not, pancreatic cancer. So that in and of itself will give you a clue as to some of the mechanisms of the pain. But let's use, really broad terms, the neuropathy of cancer pain, the visceral nature of pancreatic cancer pain, and the somatic of pancreatic cancer pain. Now that pretty much covers all the type of pain that we would manage. So, the neuropathy, neuropathic pain, visceral pain, and somatic pain. Those three terms that everybody will be very familiar with.
Mm-hmm.
We'll start with the first one, so the neuropathic element to pancreatic cancer pain, and that is, potentially the trickiest part of the pain to manage. And a lot of that is to do with the location of the pancreas and where the pancreas is located in the abdomen and the bundle of nerves that it's near, the celiac plexus, and whether or not you have actually invasion into that structure, or whether there is, and the more I've read about it, whilst I don't pretend to understand all of the neurons and the neurotoxicities and the sensitizations of neural cells, I'm thinking of it like a neural soup. There's lots of interactions of cancer cells, of vascular cell interactions. All of these interactions promote inflammation. All of these interactions promote desensitization. All of these interactions are lowering the pain threshold for that person. And all of them are obviously sending messaging up to the brain saying there's inflammation happening, there's desensitization happening. There is the messaging saying that there is distress here from things that shouldn't be occurring. So that's just a very small snapshot of the neuropathic element to pancreatic cancer pain. And that's the stuff that can be complex to control. Then if you think viscerally, the pancreatic, so from pancreatic cancer, you can get biliary obstruction. The organs that it's directly near, the stomach, the duodenum, liver capsular pain, liver metastatic pain, ischemia, all of those things will contribute to the idea of visceral pain. And for pancreatic cancer, when we talk about somatic pain, we are talking about when it has metastasized to areas like the peritoneum, to areas in the other areas in the abdominal wall, to areas like bones. And we know that pancreatic cancer pain typically metastasizes to bones, to liver, and to lung. So, with the somatic part, especially with pancreatic cancer, and when it can be difficult to control neuropathic pain is when we are also trying to control peritoneal or abdominal wall pain at the same time. So I've just touched on what potential causes for neuropathic, visceral and somatic can be. The other thing that we need to consider is what other causes of pain might there be? What other, pathophysiology could be explaining that? And once again, I think nurses, we always ask those questions well. So it might be something, and actually, James, I'll just get you to bring up the slides for me, if you wouldn't mind. I've got some slides, which you'll all get a copy of.
Josh, before we go on, I love that. I love that, and I like the analogy you used of like a neural soup. I love that.
Yes.
And I think that I love those terms that you pick up that you can, when a patient is saying to, when they're saying to you, why is this so difficult to manage?
Yeah.
People can use little bits of what you've just said to explain why this pain it's so complex. It's a soup of different depths of pain, which needs
Yes.
different types of treatment. So that explanation was really helpful. Thank you, Josh.
And I think the other thing is too, whenever we think of, I mean, any cancers in the abdomen, often the pain is poorly localized. It's generalized. People can't point to one area and here the pain is. Often there's referred pain to backs and shoulders. And I think, and that is also the nature of visceral pain. It's not like a scratch where you can say, oh, here's my pain. It's difficult to say where it is. Hence why I think people can have difficulties describing it, giving it words, all those sorts of things. So that's another thing to think of. Those visceral pains are not going to be something you can point at and say it's here. That's just another bit of information that I've sort of found useful.
Can I know you've got this slide here that we're going to talk about, but it would now be, or you tell me, would now be a good time. What I want to ask you is when we're doing an assessment, could we go talk about assessment, Josh? Is that okay?
Yep.
When we're doing an assessment of these patients, what are the key words and descriptors that you listen for that give you a clue that this person has pancreatic cancer pain? Are there any, or is it too difficult?
Look, I don't know that you could say there are, that you'll always hear these particular words from patients, because I don't know about, the 124 other people in the room with us. But people, when you ask them to describe their pain, people find it hard to describe pain. And we're often having to cue them with words like, if we think pancreatic cancer pain, we think there's going to be a neuropathic aid, part to the pain. We'll be feeding them words like burning, stabbing, pins and needles. We'll almost feed. Sometimes you get someone who's very articulate with their pain, but more often than not, people aren't, I find, incredibly articulate in the way that we would want them to be about their pain that would give us clues. But I guess when someone presents even at diagnosis of pancreatic cancer pain, they're classically going to have abdominal pain. They're likely going to have back pain. They may be presenting with sort of a jaundice, an obstructive jaundice, which may not present as pain. They might be presenting with nausea and vomiting, or anorexia, weight loss, those sorts of things. And in terms of assessment, I would expect, and we were talking earlier, I was looking after someone today who has pancreatic cancer pain, and all the pain he had was not what I would have expected, which would be abdominal pain, referred back pain, potentially distension, right upper quadrant pain or left quadrant pain, something near where the cancer is how I would expect it to present. And for the causes that we've just spoken to previously.
So is it really more for you're so right, because it is there's so much going on in the abdomen, potentially. So really, when we're assessing a patient who has pancreatic cancer, really key things are knowing what you're dealing with. Is that key?
Knowing what you're dealing with, but I think also knowing, well, what else could it be? For example, chronic pancreatitis can present in a similar way to pancreatic cancer pain. They'll have a lot of the same traits in that. Someone who's constipated, now that might also be contributing to pain. People who have had surgery and have adhesions may present with similar abdominal pain. What other reasons? So if you've a side effect of treatment, peptic ulcers, this sort of cohort may have that type of presentation as well. And then I guess with pancreatic cancer, you get pancreatic enzyme insufficiency and then malabsorption. So, you're going to have people that aren't digesting their food properly, that aren't, early satiety, gastric outlet obstruction. All of these things can present in similar ways, and some of them potentially have reversible treatments. For example, constipation. Using opioids, you always make sure that you prescribe laxatives. But I suppose, when we're thinking of differential reasons for these pain, there are some of the differentials that we would be thinking. And one of the slides, the next slide after this, just talks to all of those things that I just mentioned. So you'll get a copy of them. But obviously, I guess by the time we meet them, we know we're managing pancreatic cancer pain, but you can also have all these other things on top of that.
Yep. Thank you, Josh. And I have one more, so it's related, I promise. I have one more question associated with that. What
Yes.
about physical findings? Is there anything when you do an abdominal assessment that would make you go, oh, pancreatic cancer, or is that not a thing?
Well, I guess it depends also if you've got metastatic disease, so you might have liver capsular pain, you might have liver metastases, some of them might be palpable. Malabsorption, they might have distended bellies. Either they may already be constipated or not. There might be surgical incisions, all of those sorts of things that you would expect to see and observe from an abdominal assessment.
Okay.
So can I say there's anything specific to an abdominal assessment for pancreatic cancer? No, other than you are absolutely going to assess the abdomen, and you are absolutely going to, assess pain and tenderness and all of those sorts of things.
Yep. Okay, thank you, Josh. So really, we're looking, it's about getting the patient information before you get there, right? Knowing what you should do.
Yeah.
And thinking about what are the alternatives too. What else could be causing pain?
Yes, exactly. What are those differentials? And that, as we were saying earlier, is critical to asking why. Why am I seeing what I'm seeing? Is this just pancreatic cancer pain, or is it the neuropathic part to that, or could it be something else that we also need to consider?
Okay.
And I guess the other thing is, who else do we need to involve in the assessment of that cancer pain as well?
Yeah.
Because when we're assessing pancreatic cancer pain, and this is what the literature says, that and we'll always assess intensity of pain through visual analog scales or distress of pain. We also really need to address the temporal aspect of pain. I think that's critical to this. And the other part is the quality of life. So we know that a lot of these patients will present with depression and anxiety at the get-go. So what tools do we have in our bag to assess for those things whilst we're assessing for pain? And that really talks to the multimodal aspect of pain assessment. And that's not just up to nurses. That's up to, a lot of it will be what services you're working for and who's in that team. But obviously allied health are going to be critical to that, to that assessment. Our medical colleagues are going to be critical to that. Our psychologists, if we have them, our social workers, all of that team are going to be really critical to the management of and assessment of that person's pain.
Absolutely. And that article that you've just popped in front of us all there, Josh, does that speak to that? Is that?
This is the article that's really informed my information for this presentation. So I encourage you all to look at it. It's from an article I wouldn't normally read, Pancreatology. I think probably surgeons and gastroenterologists are the main contributors to this magazine. But there's a really terrific, the article is terrific, but the supplementary material, which is a Word document at the end, is also really interesting and actually very readable. So anyone who's interested, please find it. Yeah.
Great. Okay. So Josh, I then, we've talked about assessment, and I then want to, before we move on to management, pharmacological and non-pharmacological, I want to ask the question I asked you at the start, and we might not be able to get there yet, but what is it about this pain that makes it so tricky to treat? Why do we come across patients who this pain isn't well managed?
Yeah, look, I think you'd have to say it's the neuropathic element to the pain, because of the proximity to the celiac plexus and all of the nerves and inflammation that are attached to that. And whilst we know that, strong analgesics will have an effect on neuropathic pain, they won't always control all of the pain. And you'll have to use, we'll talk to that, the other adjuvant medications often at the same time, and often, starting at the same time for these patients as well. I also don't think we can underplay that these patients are usually diagnosed at a late stage of disease.
Yeah.
So they are dealing with a life-limiting illness almost from the get-go. So I don't think you can underestimate the psychological impact of that.
Yeah.
And the psychological distress of that, especially when it's, not only younger people, anybody would feel that, but a lot of younger people are, diagnosed with pancreatic cancer. And so I don't think we can underplay the psychological aspect. Whilst we can have an appreciation and understanding of the pathophysiology, often our services aren't well equipped to handle the psychological aspect of this whole pain experience.
It's that concept of total pain, isn't it? It's
Yeah, that's right.
This person is a person who is multidimensional, and the physical is one aspect, but if we're just thinking about physical, we're not really getting the whole picture of.
That's right. And I remember I met a young man recently with a diagnosis of advanced pancreatic cancer at the get-go, a young person, young children, you sort of retired at a young age because they could, and just the psychological distress, and to add insult to injury, needle phobia. So, and hadn't yet started chemotherapy, and was just in a pain crisis from, the very beginning of his diagnosis. Also, a significant component of anxiety before diagnosis, which was then compounded by a diagnosis. So, people are complex.
Yeah.
And we see them at very vulnerable stages. We meet them at very vulnerable times.
Thanks, Josh, for answering a sticky question for me there.
That's all right.
Now I'm going to get to what I think is what the reason that people have joined us today is. I'm going to get you to try and tell us what you do as a nurse practitioner, palliative care nurse practitioner, when you have these patients with this tricky to manage pancreatic cancer pain.
Yes.
However, before I do that, before we go to pharmacological, could we explore, have you got any, I think everyone really wants our patients, if they don't need to use the medications, you'd prefer them not to. Can you think of any non-pharmacological solutions for pancreatic cancer pain, or things that will help?
Look, I think there's a whole suite of those things, but would I use them when I first meet someone? Gosh, probably not.
Yeah.
Because we know that we need to really offer them treatments that are going to be effective and quickly. Yeah. When I look at centres like the Chris O'Brien, Lifehouse down in Sydney, and the integrative therapies that they've got, that people are offered at diagnosis and during their treatment. Use of cannabis products, acupuncture, hypnotherapy, art therapy, music therapy, and all of these things that are really treated in a very respectful way and are staffed appropriately. And none of these things come cheaply, would be the other thing that I would add in the context of services like that. But and we're not all, certainly New South Wales Health doesn't have all of those things at their fingertips. But, absolutely, you would do that. A heat pack, for goodness sake, can make a big difference. Can't it?
And I think that just goes back to this concept that you were saying before, of this total pain. It's like, so we're going to talk about this pharmacological, the treatments, but actually a person is a whole being that needs that there's more to them than just the physical. So, so probably just the point of that is to say that if you've got team members like physios and OTs and massage therapists and music therapists, they can play a key role in social workers in the care of the
Yeah, absolutely. And often they can lead the way. Our OTs in our service are leaders in patient assessment and management. So I think first thing would be is we are not alone in the management of these people's pain and families' pain. Often it might feel like we are. We shouldn't be. Certainly in the community, the GP is going to be core to that pain management when it comes to prescribing. If there isn't, or even if there is a nurse practitioner around, we still keep GPs at the centre of that. Our palliative care staff specialists are also going to be critical to that. The people that they know, like pain specialists and anaesthetists, are going to be critical to that. Gastro teams, if some sort of surgeries have been involved, like pancreatic duct stenting or gastric outlet obstruction stenting, or bile duct stenting. So there's a whole crew, medical and non-medical, that will be required.
Thanks. Okay, so then the question that everyone's come for, Josh,
is $1 million question. Yes.
So if you have a patient with pancreatic cancer, pancreatic cancer pain, what regimes, where do you start them, and what do you do? What can you tell us?
Look, I mean, what's that old song? You start at the very beginning. I mean, that's a good place to start. Where do we start in palliative care? So we do our assessment, and then we know there's the World Health Organization analgesic ladder, and that is still a go-to. There might be a step of the ladder that we may not commit to as much as others, but we would always start with paracetamol. Stick to your core principles. And then the next step is, can be non-steroidal anti-inflammatories, things like tramadol. We may or may not go to that step. We might go straight to the next step, which would be strong analgesics. And once again, the normal principles of pain management, short acting in the first instance. Sometimes you may, depending on the actual presentation, start with long acting straight up with some rescue medication there. And certainly for pancreatic cancer patients, if they are clearly talking to a neuropathic element at the start, you might start someone straight away on a neuropathic pain relief, just for an example, pregabalin 75 milligrams BD if they're sort of a fairly robust adult, rather than around with 25 milligrams at night. You might start straight at 75 milligrams of pregabalin BD straight up, as well as your morphines or OxyContins, whatever you're going to be using. And obviously, looking at renal function, looking at liver function, all of those things in the context of that prescribing. And, in terms of adjuvants, I just mentioned one of them, anticonvulsants. Also, antidepressants can be used. And, there's limited evidence for all of those things. There's good evidence for the use of opioids. And then I guess the big question is, when you're throwing everything you can at it and it's still not working, what do you do then? Who do you involve? Who do you call? The other critical team players here are, of course, oncologists. And we know that chemotherapy is going to be core to pain management. It'll reduce tumour burden. I guess the question for us is, who's the right fit for that chemotherapy? We know, I think it's FOLFIRINOX and gemcitabine. They're things that we use routinely in oncological settings for these patients. And they can potentially get good pain relief from them. And even someone who has a palliative diagnosis may still be offered these treatments to prolong their life and to reduce their tumour burden. So that's a really critical part of this conversation. And the timing of that, when does someone commence on those things? And then if we're also talking about timing, it's like, well, if you've used your opioids and you're using your adjuvants and you've used your pharmacology and it's still not working, when do we then go to what everyone sort of talks to, blocks, the idea of celiac plexus blocks? How do we access them? Who do we talk to? What's the right time for someone to have those? And, there is no right answer to that. I'll talk to firstly just the timing. So the evidence tells us that the people who are going to benefit most from blocks are people who are probably end-stage disease, people who may be dying in short months, because a block might be effective for 4 to 8 weeks, probably more like 4.
Josh, can I ask, just for everyone in the room who probably a little bit like me and not that clued in, or actually, no, everyone might be clued in and I'm not clued in, but I ask for everyone in the room, are we talking about a celiac plexus block, like the nerve that's going into the pancreas, or are we talking about, what are we What are they blocking?
So they're blocking the structure of the celiac plexus going to the root ganglia of the spine and up to the brain. So they're blocking it with alcohol, usually, or phenol, 100% alcohol. And they can approach it either posteriorly, so CT and ultrasound guided posteriorly, so someone's laying on their belly. I think that's probably more common here. The other way they can do it is endoscopically with Doppler. And they call that bilateral, where they go either side of the celiac plexus. They can either do a single or a bilateral block. I don't think there's any evidence saying one is better than the other, or going posteriorly is better than endoscopically. The risks to them posteriorly, back pain, fibrosis is a risk to all of them. Some cases of paraplegia, nausea, diarrhea. If you're going endoscopically, thinking, are there any risks for bleeding, varices, those sorts of things.
Yeah, and the patients who can have a block like that, there's obviously there's so many factors that would contribute to patients who could have that. One of them would be at the stage of their disease, right?
Yes,
so if you've got someone who's terminal, we're probably not going to get them in for their block. But if you, I was going to say geographical location to a
huge
centre,
huge,
doable, right? But that's a big barrier, isn't it?
Yeah, it is. I think the barriers are because often, whether or not someone can get a block, it might be the relationship a palliative care doctor has with a pain specialist or an anaesthetist, and what relationships they've created professionally at the hospitals that they're at. I know where I am, we do have a relationship happening locally, which is great for patients, but you're absolutely right. Who is the right patient to benefit from this? What is the right time that someone should have this? Is it actually going to be the panacea? Is it going to, reduce their pain? That's the critical question. Is it going to be better or the same as the analgesics they're currently on? And I think it's a bit of everything. So the feeling is it might be opioid sparing. The feeling is that it does reduce pain in enough to warrant doing it, but it only reduces pain for a certain period.
Yep.
You usually don't repeat a block. If you've done it once, you're probably not going to get a chance to do it a second time. The other clincher is if you've got disease outside of this abdominal area, so in the peritoneum or abdominal wall or lung, you're still going to have sources of pain. This is only blocking pain in the visceral sort of locations. Anything above that it's not going to work for that. So, we're saying we're going to wait for people to be at the end of their diagnosis before we consider this, but also they're more likely then to have distant metastases. So there is that as well. So, it's not straightforward.
All right. Is there any, so there's the blocks, the nerve blocks. Are there any other interventional options for these patients, or is that the main one?
Look, that's the main one that's used. There are others that are mentioned in the article, but they're too complicated for me to say. There's some ablations that they can do. There's obviously radiotherapy that can happen. That doesn't happen often, but stereotactic radiotherapy, which is, using particular equipment so you're offering radiotherapy to a very specific organ, so it reduces effect on other organs. So that is used, although the evidence for radiotherapy, management of pain in pancreatic cancer, it's not a large amount of evidence, but it's there, and it may be offered. Once again, it might be, where you are as to whether it's going to be available to you or not. Sorry, go on.
I have another question, Josh. So we've talked about, the kind of what you were talking about with pharmacology was starting all the basics, right? Starting them on the opioids and the PRN and a slow release, and then if there's an idiopathic ailment, getting them on an anticonvulsant and perhaps an antidepressant.
Yeah.
Then I guess my question is, that's where I've got to in my work. What happens when that's not working and this person is still writhing in pain? Are we thinking Then, this is a bit of a leading question. Are we thinking about methadone? Is that where we go there?
Yeah, so look, the evidence for methadone and ketamine, I mean, we use them a lot routinely in palliative care. Methadone is obviously is often used as an adjunct to opioids in smaller doses at the same time while we're using opioids. If you're going to stop the opioids altogether, I mean, methadone is an opioid, but stop the opioids that we regularly use and methadone only, then they'll often be brought into a palliative care setting for that to occur. Look, yes, methadone will certainly help with neuropathic pain. It may be very effective to start in small doses, 2.5 to 5 milligram BD, and building up. But methadone is tricky. It has a long half-life. Certainly, we'd be involving doctors in the management of that, or nurse practitioners, and renal function has to be thought of. All of those sorts of things.
Yeah.
So I guess the other thing that where your question is potentially leading is if we're talking refractory cancer pain, certainly we're probably looking at a short space of time because we've obviously got progressive disease.
Yep.
And then we need to be thinking about other ways to give analgesics parenterally. And then what's the right care setting for this person to be in? And then the whole concept of trade-offs. Do you want to be awake and distressed, or potentially drowsy and have some better pain control? So that's a conversation, isn't it, with patients, families, everybody involved. And then, of course, the other thing is voluntary assisted dying and whether that's available to that person or not, if that's something they would want.
Yeah, can I ask you, Josh, how do you approach that conversation with families when you say, for example, you've got increasingly escalating medications, and that to a degree those medications, the side effects are going to make those patients drowsy. But you also know that what they want is to be awake and present for their family and their kids or their life. What are some of the words that you use or conversation starters? How do you approach that?
Well, look, I think, and this is something I've come to sort of later in my practice, and I've been an endorsed NP for 7 years now, and open disclosure is something that I would always encourage around those things. Like, I think we need to say, here are some of the side effects of the medications that we're going to use. Yeah. And someone's in really great distress, they're probably not going to, it's not going to matter too much, but it's really family members also that almost need to hear that. Yes. Here's the burden and benefit of the interventions that we use. But, the other thing, the tenets of palliative care are we never go in boots and all. We start very judiciously.
Yes.
And, if we're going from oral to subcuts, we'll often dose reduce in the first instance anyway, so that we're not going to make someone unrousable. Rarely do we make people unrousable. We know when people are unrousable or people are really drowsy, it's always multifactorial. In terms of making people, more sedated, we can do that slowly in the first instance with light sedation and build up as we need. So, it's a nuanced conversation, but we haven't got a reputation for being, really clumsy around that stuff, do we?
And I think that's a great line, actually. I love that with patients to be like, palliative care, actually, we have a reputation of going slowly. And our approach is that we go really cautiously. So you can
that's right.
That's right. Dose that you're getting is really
but also when it comes to it, if it's a pain crisis, we can go from 0 to 100 in a day if we have to, if they're in the right care setting. It's hard to do it in the community. But we, and that's the other thing, it's important for people who are in the community and who want to be home and whose families are managing pain. I always reassure families that they won't cause harm by giving the doses that we suggest, that they're not going to make someone die by giving the doses or the medications that we suggest, that families don't have to second guess what they're seeing. They will always be right. I think those messaging, it's really important around this as well.
Absolutely. Yeah, absolutely. And actually that leads on to another question, Josh, if that's okay.
Yeah.
which is so we've actually got lots of disciplines, I think, here. But say, for example, if you're putting on a community palliative care nurse's hat and you're in a home with someone with pancreatic cancer and you're setting up their medications, what do you think's really important to tell the carer and the client? What do you think, what extra supports do they need to be at home managing pancreatic cancer pain?
Gosh, what extra supports?
I think you spoke to it actually.
Pardon?
I think you actually just spoke to it actually, which is that you kind of need to be telling them to not second guess themselves,
Yeah. I mean, I think also, making sure they've got adequate supply, they've got a reliable supply of medications. I know that can be tricky depending on where you live. Community pharmacists may not stock subcutaneous methadone. They may not stock hydromorphone, all the things that might be really core to what we need. So making sure there's appropriate access, having good relationship with your pharmacists. And I remember one thing that the pharmacist said to me, if you tell me it's a palliative care patient, we will go above and beyond. So always tell your pharmacist, I'm looking after a community palliative care patient, and they will really do what they can for you. And then, of course, this is the whole MDT approach to it. Who else needs to be involved? Equipment, pressure relieving equipment, all of that stuff that would go for anyone who's dying at home from any cancer.
That's helpful. Thank you, Josh. So now I think what I've got from this, we're going to open it up to questions in a minute, Josh, but actually what I've got from this topic was here because I was curious and I'm hoping everyone else was too, is actually that we treat this pain in the same way that we treat other pain, right? Like, and it's multimodal, so we know it's got nociceptive and we know it's got neuropathic elements, but we still approach it in the same way that we would others. Is that a fair?
Yeah, and look, I think that's really true, because when a situation feels too complicated, you just pull it back to basics. We know how to assess pain, we know how to measure pain, we know what medications will have an effect on pain. So you'd go to all your basics first up. There's no expectation that we at nurses know how to do blocks, but we do need to know that they exist. We do need to know how they would be sourced where we live or not. We do need to ask the cause of pain. Are we managing pancreatic cancer pain? And if so, what are the aspects that we've mentioned? Neuropathic, visceral and somatic. You can apply that to pretty much across the board, but specifically to pancreatic cancer pain, what organs would that involve and why? So I think just keep asking why, back to basics, understand what you're treating.
Yeah, thank you, Josh. So before I open it up to questions, is there anything else you'd like to say about management of pancreatic cancer pain?
Look, I guess just be courageous in your assessment. Be honest with your assessment. It's okay not to know. Yeah. Be present. I think, nurses, we're very available. And I think just being available to someone in the home means a lot. I know this young man that I met, really before any of the other health professionals, the oncologist, the palliative care doctor had met. I was in there, boots and all, managing things. And I was available, and that meant a lot. That meant they could go to a concert because they felt confident with what they had been told by us. They could call us and we would answer. So I think that actually means a lot. Don't feel as though you have to know it all.
Yeah, that's great advice.
Yeah.
So what I would like to do now, and I know that Aileen has been there looking at the chat, but if anyone is sitting there, I think we still have 120 people there, so that's pretty awesome.
At least we kept their attention.
Yeah, I'm so pleased everyone stayed. Does anyone want to pop in? Of 120 of us, I'm sure we can think of one question. Has anyone got a question that's sitting on their mind that they'd like to ask? I've got one if you don't.
Or has Aileen sifted through questions and has one ready for us?
You could unmute.
There are 4 questions at present in the chat. There
Okay.
are
Did you
a
say there's
couple
none?
of comments, however. I think Annette's is a good one about helping people decide about celiac plexus block versus analgesia only. And I think that talks to the point about context, doesn't it? Where people are, whether they've got access to that kind of
Yes.
conventional
And
service.
knowing that the literature is telling us that it's usually people in the latter stages of their disease that will benefit from a block.
So interesting, but so tricky, because people in their latter stages of their disease might actually not be able to get to hospital.
Yep. Yeah, or they might be in hospital in a pain crisis and be able to access it, but will they live long enough to benefit from it? That's the other thing.
Josh, my question for you is, and I've got a community palliative care nurse hat on always. So if you've got a patient with pancreatic cancer and we've decided there's a neuropathy element and they're on an anticonvulsant, an antidepressant, and that's working, what do you give them for their kind of support medication PRNs?
It would be it would probably be an opioid, because they would presumably be on a long-acting opioid as well. So that would be what I would be having for PRN. Occasionally you might have methadone. Once again, that is an opioid. But yeah, it would definitely be a strong rescue analgesic. Yeah.
And is the point of that really to say that opioids do work a little bit on neuropathic pain? Is that right, Josh?
Absolutely. Yeah, I think they do. I think they do a good job on neuropathic pain until they don't. Yeah.
Right. Now, we have a question that is off topic, but also kind of awesome. Amy Hooper has said to us, what is the best type of antiemetic for nausea and pancreatic cancer? So why don't we answer that too? Josh?
Look, I guess just quickly, are they on Creon? Are they, on something due to the lack of pancreatic enzymes? That would be one of the first things I would say. And then often something like metoclopramide might be a good place to start with gastric, emptying. But I guess once again, it's not a recipe for antiemetics. You have to go to the mechanism, the cause. What do you think the cause is? How's the person describing it? What's the best antiemetic to work on where you think, what receptors are being triggered? So it's not a recipe, it's an assessment.
And actually, Amy, we've got another webinar on nausea. So we might, we'll be able to maybe cover that a bit in more detail in another webinar. Maria.
Thanks, Kate, for that. Yes.
Maria Heaton has asked, hi Maria. Maria's asked, if a person is non-verbal or has a cognitive impairment, how would you approach managing their pain, which is likely to present as a behavioural issue? Oh, that's a tricky one. Josh?
Well, I think Maria's just answered that, likely to present as a behavioural issue. So we know that there are tools for people with cognitive impairment, like dementia, Alzheimer's, all those sorts of things, and Abbey Pain Scale. So you're looking at behaviours, mood, eating, not eating, grimacing, not grimacing, all of those sort of domains of assessment from observation. And obviously the people that care for them, who know them well, would also be helpful in that assessment.
Yep. I've got two other really great questions for you, Josh. Kate McClelland has said, would you consider a syringe driver for acute pain, an acute pain crisis of pancreatic cancer?
No, well, no. A pain crisis essentially to me means they've got unstable pain. So, and once again, it might be dependent where they are. You might need something in the background just to start, but usually if it's unstable pain, they're in a pain crisis, you're going to be using short-acting often, lots of it available, and getting a sense of what their pain requirement is before you start a syringe driver.
Yeah, cool. Another good one here, and Nikki Wells has said, I found pancreatic cancer often the trickiest to deal with in pain management. Is this something you've experienced too? Often pain can escalate very quickly and is very changeable. And my answer is absolutely yes. That's why we're having this webinar, Nikki. You're not alone. It's really tricky.
Absolutely. Yep.
do you think, Josh? Do you agree?
Yes, I agree. And often they'll present you to pain crisis. So right from when you meet them, you're dealing with a lot of distress and you're really chasing your tail and you're in there evaluating and assessing every day, or, in the morning and afternoon, depending where they are. So yes, it presents a big challenge, but I do say just take a breath.
Yeah.
You're not alone. Go back to basics, involve the people that you need to involve, and you will be able to make a difference.
Yeah. And another question from Roger Hunt. He says, could lidocaine syringe driver help for patients with tumour infiltration of a celiac plexus?
Look, it sounds like, Roger, you've got experience in that. Maybe you've known patients or palliative care units where they've needed it. Maybe it would be an answer to that. I don't think there's any huge evidence around that, but certainly, we use lignocaine topically and subcutaneously to manage tricky cancer pain. So yeah, I guess yes, prescriber dependent, I would say.
Good job, Josh. Good answering questions. And then another question from Tony. These are great questions, by the way. Thank you. And everyone's still here, which makes me very happy. Tony War has said, have you noted benefits from NSAIDs for pancreatic cancer? And which is your preferred option? That's a good question. I want to know the answer to that.
It's a good question. Look, yes, no, occasionally using NSAIDs if you think there's sort of an acute inflammatory cause. But NSAIDs, you can only use them for a short period of time, usually a burst. But is it my go-to? Absolutely not. I mean, it might be something that I use as well as occasionally, maybe something like Celebrex, but honestly, it's not something that I would use often and go to often. Often because of the side effect profile of those as well, with peptic ulcers and all that sort of stuff. And the fact that you've got to be in there actively telling people to stop them. So, yeah, that's often the step that we don't commit to in the analgesic ladder, I would say.
Yes.
Yep.
Thanks, Josh, and thank you everyone for your questions. Before you leave, I'm watching the numbers, so don't leave yet. We're going to put up a quiz. A survey, a survey just to get your feedback about this webinar. PCNA will have 2 webinars a month this year, mostly, and they are hopefully going to be topics that are interesting and useful to you. So we need to know whether this style of webinar is useful, whether it's accessible, understandable, and whether it's something that you're willing to come back and do. So James, are you going to put that up for us? Thank you for still being here, everyone. I'm watching the numbers. No one's leaving. Thank you for coming. And thank you, Josh, for your expertise.
Not at all. I learned a lot, and hopefully it was useful. It was a useful talk. So I enjoyed it. Thank you.